One of the ways to reduce the wait in A&E is to send them somewhere else. Who's going to do that? Because if you wait to see the nurse practitioner, she's done half of what she needs to by the time she realises somebody else could do it. It doesn't take much to tip the balance either into a crisis or back out of it. One hospital I'm working with, if they have 200 patients go through the department in a day, they're coping and it feels quiet to them. 220 and it's a crisis. So if we could manage the department so that 20 patients could be seen more quickly, that doesn't sound a lot, but it makes an enormous difference. There are several changes that could occur in emergency departments that some departments are already using. One of those changes is in the minor injuries areas, having separate staff in a separate area so that work can continue whatever's happening in the other side of the department.
If it's a 999 call rather than a 111, a police or a GP, and that is about 85–90% of the calls, that's what we've included. And from the study we've done, about 9% of the population would be either frail or have more than one long-term condition. What we've found when we've looked at the data, though, is that 27% of the attendances at A&E are from that population group. There is the potential to improve the 95% the A&E 4-hour wait target because you're reducing the pressure on the system. Because of that, you're also reducing the risk of sort of overflow into an admission to hospital, and you're basically enabling the current system to manage much more effectively by addressing needs even before one gets to A&E. And on sort of the simulated outputs at the moment, with fairly modest ambition within the community, we've seen the potential in terms of saved admissions of about £2 million in a large city environment of maybe 700,000 population.
Modelling allows you to actually build a dynamic representation of your system and then actually play with it and say, well, what if this was to happen? What if I did this? And actually lets you play with the numbers and see what the impact of changes would have. So it doesn't cost you to try these changes. You actually try it virtually on this model.
It definitely is a different way of thinking. We're often firefighting in the NHS to improve things, and actually sometimes we've got to think outside the box and think forward and look at what we know and what we can predict.
The stress that the NHS is under at the moment means often there's a temptation to have quick actions with quick results, and history shows that often those aren't sustainable. What we had been doing, the work of the Cumberland Initiative, is to be able to model changes that look at the longer term, so we can show that they'll create change that is then sustainable and will prevent the crisis from occurring in the future.